So processing is a key element in the use of forward thinking. Forward thinkers always are processing as they're navigating through the patient's symptoms, and we're going to work through the concept of forward thinking. We're going back to our patient Sophia. So in forward thinking, the clinician attempts to elaborate on the problem representation before they explicitly consider the differential diagnosis. They get more history and they look for clarifying physical features to help develop the best problem representation they can. And along the way, they're going to use processing to put that into a medical shorthand that's actually very precise. The differential diagnosis is then informed by the enriched problem representation, and it tends to be much shorter so that people don't get as tired as they're working through it, and much more relevant to the some holistic view of the patient's clinical presentation. In hypothesis testing, the problem representation was very sparse. It functionally was a symptom, just an isolated symptom. But in forward thinking, the problem representation focuses on a syndrome. This leads to much more efficient data gathering because once we begin to look to refine a syndrome that we're aware of, we look for specific information in each step of the process to narrow the differential diagnosis. And the key skills that are needed are our skills of processing and the compare and contrast thinking, where we understand how different diseases look for and demonstrate different features. And those are the ones we'll be seeking out in our patient as we move forward with our problem representation. So here's Sophia. Again, her history and physical. A 17-year-old woman complains of leg pain for 2 days. If I'm going to use forward thinking, rather than just focusing on leg pain, I'm going to begin to define the problem in a more robust manner. And I'm going to look for elements that are compatible with my disease illness scripts. Again, time course, epidemiology, syndrome statement, and the mechanism of action. So time course, she's had it for 2 days, and using processing, we would say that that's an acute presentation. She said she's felt tired and feverish, but most importantly, she's had this painful elbow, this leg pain, and this wrist aching. So I'm curious about that because it's 3 types of limb-related phenomena, and I'm going to want to know what kind of limb-related phenomena. So I look a little bit further and find out that this left ankle pain is not just generic leg pain. In fact, there's evidence of inflammation, redness, warmth, and as we talked about earlier, pain on movement. And in addition, there's other important elements of her feature that I think are quite unique, and that's the funny spots on her hands. So I'm not going to start with a differential diagnosis of leg pain. I'm going to take all of this information, process it in a way that makes it useful to me, and I'm going to allow that to help me navigate through my ideas about what might be causing her symptoms. So based on my questioning and investigation of Sophia's presentation, I can show what her symptoms are in a processed manner. First, duration. Her symptoms were here for 2 days. That's acute, and we'll show how this helps you in forward thinking on the next slide. There's evidence of distributive processing. Remember, where does this present in relationship to the body? And we would call this oligo or posse, meaning a few, more than one, less than a bunch. And qualitative processing, she has as the cause of her current leg pain at least arthritis. And we know this because she has joint redness, warmth, and tenderness to motion, which are the elements of arthritis. It's not simply pain, which would be arthralgia. So again, very precise about what's causing her leg pain, how it's distributed, and the duration of her symptoms. This is the beauty of processing. And this is how it helps you with forward thinking. So instead of starting with a differential diagnosis of leg pain, I started with a differential diagnosis or concept about arthritis. And I'm trying to increasingly make a more sophisticated problem representation of that arthritis before I establish a differential diagnosis. So walk with me through this series of branched chains, and you can see how I might be thinking about clarifying Sophia's problem and limiting the differential diagnoses I have to consider. So first I say, well, if she's got arthritis, I need to know, is it a single joint, multiple joints, or just a few joints? So I'm going to say she's got oligoarthritis. And then, well, if she's got oligoarthritis, is this an acute problem or is it a chronic problem? Well, it's an acute problem. Does it have a rash or no rash? Well, it's got a rash. Remember, we talked about those spots. And is that rash diffuse, meaning all over her body, or is it discrete, meaning there's just small spots of it? We're going to call it discrete. And with that, because I know that patients who have acute oligoarthritis with rash, especially discrete rash, that can be associated with a small set of diseases that I know from my previous reading. It could be a sexually transmitted disease, a diarrheal disease, or pharyngitis like Jeremy had. And each of these symptoms might lead me to a different set of differential diagnoses. But I'm concerned that she has a sexually transmitted disease because she's sexually active and she doesn't have any symptoms relevant to those two conditions. So the number of differentials I'm considering is now really quite small. Disseminated gonococcal infection and maybe some other ones. Instead of what I might have to consider if I was using hypothesis testing and only looking at the symptom of leg pain.